Good morning, everybody, respected chairperson and dear colleagues. Actually, today we are going to present 4 difficult cases of pelvic SOLs which were dealt with robotic surgery with excellent result. We have got 2 centers in Hyderabad. One is Medipatnam and Gachibowli, and this is the team we have done it last 3-4 years there. The first one is a pelvic myxosarcoma. A 45-year-old man presented with lower abdominal pain and no bladder or bowel symptoms, no loss of appetite. PSA was normal. In fact, on ultrasound there was a big SOL of 8.3 into 5.8 into 6 centimeter in the pelvis, probably from the prostate, because it was not clear such a big one how it is arising from. MRI showed a large heterogeneous soft tissue neoplasm in the close relation to right lobe of prostate, which was compressed. And core needle biopsy showed spindle cells in the bundles, showing myxoid stroma, probably a low-grade myxofibrosarcoma. That was the pre-operative diagnosis. If you see the CT scan here, this is the bladder, this is the rectum, and in between there is a cricket ball-like rounded SOL here, which was solid and cystic some places. So this was surprising that such a big SOL was present between bladder and rectum without infiltrating them, and it was around 11 centimeter on the whole. You can see it is oblong at one place, and this is a person whom we have taken up by robotic surgery, considering the complicated location as well as the inaccessibility of that area by laparoscopy or by open surgery. And we have a SI system in our place. Now this is, as soon as we entered, we saw this is the space occupying lesion. Separation of the mass between bladder and rectum. It was a challenging task because in front there was bladder and it was tightly abutting both of them, but fortunately it was not infiltrating. So we could actually go between them slowly. We have taken about 2 hours to just go around the SOL and without injuring the bladder or rectum. If you see, we have bagged it here. It was very big. The bags also were very tight inside because generally standard bags can take up to 10 centimeter, but this are 11 and 12 centimeter on around. The histopathology showed that there was smooth recovery and patient was discharged on 4th day. The drain also was not much. On 3rd day we removed it. And biphasic population predominantly spindle cells interspersed with glands, mild to moderate dysplasia, and changes of mitosis entrapped in the glands of prostatic origin. It was spindle cell mesenchymal tumor of myxoid origin involving prostate. Now coming to the second case, a 23-year-old boy presented with lack of secondary sexual characters and was treated with hypogonadism for testosterone, and he had normal penile cells but no facial or chest hair, and abdominal fat was significant. There was inguinal testis which we have done orchidopexy. There was on ultrasound there was 15 into 10 centimeter cystic lesion in the pelvis, a piriform shaped SOL. This is abdominal girth showing a lot of fat in a 22-year-old boy and mild gynecomastia also. Now this is orchidopexy on one side. This CT scan showing this is the piriform shaped SOL which was soft cystic, lot of fluid collection inside. And if you see in the vertical area, this is the bladder in front and rectum behind, and the one which is projecting upwards is the probably molar duct cyst, because the mucus what was seen was surprising. It was not a tumor at all according to whatever CT scan images and MRI images. Now we have taken up by robotic surgery. This is the SOL which was attached to the pelvic wall here and there, but not very tough. It was not infiltrating. It was looking like a benign SOL. We have cut off the attachment to the pelvic wall. This is a left horn. Now see here, gently we have dissected left horn of the mullerian duct cyst from surrounding areas. It was not actually attached to the rectum or bladder in front. So when the dissection was getting tough, we aspirated it and it was a cloudy liquid. Lot of fluid has come. About half liter of fluid has come out. After that the dissection became quite easy. So once we have done the left side, we have proceeded to the right horn dissection, and in the pelvic area, as it went down to the pelvis, we have cut it off because we are not sure how far it is going down, and whatever we could see, the wall was excised from below and it was not closed. It was just left open because there is nothing. The inside mucosa was burnt so that it won't produce any mucus in future. This is the specimen looking like a uterus. The left horn is quite long, right one is rudimentary. This is a post-operative. 2nd day, he was discharged on 3rd day. There was no operative or post-operative complications. This is 1 year later. His abdominal fat has come down little bit of the testosterone supplement was continued, little bit of facial hair was coming. The third one is a retroperitoneal fibrosis. A 35-year-old man presented with vomiting and facial edema of about 10 days duration. His creatinine was fluctuating between 1.3 to 4.5 milligrams, and there was bilateral mild hydronephrosis. The CT scan has shown that bilateral hydronephrosis and the ureters are drawn medially and compressed. You can see the classical fibrosis where ureters are actually pulled towards the midline, and then we have put a double J stent. Stenting was not difficult. There was no obstruction anywhere, though the obstruction on the CT scan was here in the mid part, but stent has gone easily. Now, we have taken up a robotic surgery after the creatinine has come down from 4.5 to 1.9 within about 1 week. So ureters were actually freed from the retroperitoneal plaque, which sometimes it was calcified, hard. We had to cut it with difficulty, and then after excision, the ureters, without injuring the ureters, we actually sterilized them. And then this is the last case, sir, a 50-year-old lady, obese lady, who had a mass health checkup and showed a 3 cm SOL in the left renal mass. Now it showed that there is an exophatic tumor, and if you see, this is the CT scan, plain CT, there is a hump here or a bump here on the cortical area of the left mid pole joining the upper pole. On contrast enhanced CT also, there is a little bit of enhancement, but not much. But the tumor stays, it is actually merging with the renal parenchyma. We have taken up, there is no distortion of the pelvic action system, and we have taken up by robotic surgery. We have taken the hilar control here. This is the artery, this is the vein, and once you have taken control of the artery, we have done the partial nephrectomy without any bleeding and with a very little of ischemia time, basically because it was a small tumor of 3 centimeter. It was easy to cut it open, and then after the repair also, there was no complication, there was no distortion. Now there was smooth recovery and discharge by evening. Advantages of Robo, or it is a future of urology. It's a good access to deep areas, 3D visualization, magnification, endoscopic instrumentation, pinpoint dissection, and decrease surgical fatigue and tremor, and great help while dealing with complicated anatomy like this sort of 4 adverse situations. Thank you, sir.
Thank you. Can we have a next?